Welcome to Research Perch from the Massage Therapy Foundation. Short, practical insights into massage therapy research and how it can benefit your practice.
Co-chair of the Massage Therapy Foundation Marketing Committee, and here as always with Nikki Monk and Ruth Werner. Ruth, how are you?
I'm great, Michael. How are you today?
Doing well, aside from my allergies, as we talked about last time. Nikki, how about you?
Fantastic, thanks. As I drink my water.
Nikki's fueling up for this episode. Glad to see it. So, all right. So, thanks so much again for joining us. As I mentioned, Research Perch is a podcast where we unpack articles from the International Journal of Therapeutic Massage and Bodywork, or IJTMB.org. For short, that's the website. You can download these articles in the full text there. But we really try to unpack these and make them accessible to you, our listeners, in a more kind of lively, personality-filled format. So is that a good way to say it? So with that, let's get started. So
you mean that in the nicest possible way, right?
In the nicest possible way. Much more personality than just reading words on a page, right? So today's article is titled "Massage Therapy for Cervical Degenerative Disc Disease: Alleviating a Pain in the Neck." So this is in fact, speaking of personality, the title on this one has a little more personality than usual. Usually we read these article titles and they're very, professional and very kind of dry and just kind of, they state the thing. But this says alleviating a pain in the neck with a question mark. I feel like they're trying to have a little fun with this one. Do you get that impression?
Yeah, yes, so. Yes.
Always nice to see when you've got a little personality in the title. It's a great place to be.
Yeah, it's nice to see that. This is from Rhonda Marie Avery, it looks like. So, So what's the background on this one?
So I'll go ahead and take this on, the introduction of this, because that way I leave the hard part for Nikki to talk about. So this is a case report. So we're back to a format that we talk about a lot on Research Perch, which is having one therapist and one client, and the client has some goals. And this was a case report winner, and I'm trying to remember now if Rhonda was a student or a practitioner. If I remember correctly, she was a practitioner from Canada, and her client was a lady in her 60s who had slow onset and progressively worsening neck pain, along with weakness and radiculopathy, which is problems with the nerves going out from the nerve roots, primarily, if I remember correctly, in the left side and her left shoulder.
Yep.
And what Rhonda Avery wanted to find out is if her skill set of massage therapy approaches might be able to help this client with degenerative disc disease. That's the DDD that you'll hear us talk about. So she does a very, very nice job of setting up physiologically what we can expect to see in an aging spine, with the degeneration of the discs and the thinning of the discs, and then the growth of osteophytes, which may conceivably irritate structures, and the pain that is associated with that then is less about the osteophytes or the thin discs and more about any number of factors that could irritate the nerve roots, including inflammatory chemicals or mechanical pressure from the osteophytes. She makes a nice point, which I make a lot when I'm talking about spinal pain, which is that X-rays or other imaging tests that show us some anatomical anomalies in the spine are not necessarily great predictors of pain. And there have been some really great sort of landmark studies where random people have agreed to have their necks X-rayed and then shown to a variety of doctors to predict where their pain was, which they did, except that the people who had submitted their X-rays had no pain. They had some anomalies, but they just happened to be in places where it wasn't irritating the nerve roots or the spinal cord itself, and so consequently, they had no symptoms and didn't need fixing. And that discovery has been very, very good for our medical community, because we're a lot more careful about automatically leaping in to fix something that is not necessarily broken, or to fix the wrong thing if we think that someone's pain is being caused by a disc or an osteophyte, and it might be something entirely different.
So, and they
Yeah.
actually call this the DDD paradox, right?
Yes. Yeah.
And it really speaks to this very interesting notion in pain of the difference between perhaps even pain threshold, so the thing at which at this point pain begins, versus pain tolerance. So they may even see a condition that they see the severity of it from a physiological standpoint might be really, really progressed, but yet this person's like, my pain's at a 2 or my pain's
Right.
at a 3. And
it doesn't stop me from doing the things
Right.
I do, which is when we want to interfere, right?
Right. And then, another person that has something that's much less severe from a physiological standpoint, and they're just in excruciating pain. So, pain is subjective, right? And then there's a portion of pain that is subjective. And we still don't know how to measure that non-subjective piece of pain. That's the big $1 million question.
Or how to compare person A's pain with person B's pain, because they don't.
Right.
They don't.
So it certainly speaks to this. But go ahead.
Right.
Sorry.
All right. So the primary symptoms of degenerative disc disease are a progressive loss of range of motion, which is not necessarily associated with pain. It's just that someone finds that in rotation or in side flexion, and definitely in a consistent way, extension of the neck becomes quite limited. Other signs will include signs of nerve irritation, radiculopathy, a reduction in the strength of the neck muscles or the arm and shoulder muscles that are being supplied by the nerves that are being irritated, general stiffness and poor stamina in those muscles as well, easy fatigue. But it is so that's sort of the basic setup of degenerative disc disease. What this writer has done for us is brought forward a hypothesis about nerve root sensitivity that we don't, that we weren't talking a lot about when I was in the classroom, which is the role of hypoxia here. So, definitely we know about if there's damage to a disc and there's inflammatory chemicals, that could be highly irritating to nerve tissues. But what we have not really looked at in a lot of detail is what happens when the musculature gets really tight, or the bony deformations create narrowing in space that deprive the nerve tissue of its blood supply. So she's making the case that hypoxia is additionally a player in this person's neck pain, and she uses that paradigm, if you like, as a rationale for a lot of the choices that she makes with the kinds of body work that she does, between the manipulation of soft tissues and adding some traction to basically boost local fluid flow.
Something I'd like to point out at this point, Ruth, that Ms. Avery does exceptionally well is she lays out that argument throughout the process of her case report of, this is the evidence we have here, and this is why I'm going to choose this approach. And she's very, very systematic in this. It's very clear why this was a gold place. I'm assuming she was a gold place winner because.
Yeah, and she did speak. I get to hear her speak, and frankly, I'm going to be embarrassed if I have the wrong person. But if I remember correctly, Rhonda Avery is functionally blind.
I've not met her, so I do not know.
Yeah. Karen Boulanger worked with her to get this ready. So it's sort of neither here nor there, but it speaks to the challenges that are met when people undertake case reports like this. The other thing she did that I really liked is that she was dissatisfied with the amount of research she could find about massage therapy for neck pain. She said she found plenty for low back pain, but a real dearth of information about massage therapy in general for neck pain. And she, gave us her list of search terms that she used and how she came up with a big old goose egg. And so she looked beyond massage therapy, and I think she was looking at some physical therapy and chiropractic papers, again, to help form her rationale for why she chose the approaches that she did. One of the things I'd love to ask you, and this is based on a research perch that we did fairly recently, the one about it was Sylvia Burns, and it was the one about working with a client who had post-concussion syndrome. So, and you were her editor, and you and she developed this lovely table in which she described the test and the rationale, and then she described
what she was doing and why she did this technique, and then
what happened, right? And so Rhonda Avery did this essentially in a narrative form.
Yes.
In a huge amount of detail. You could very easily recreate her approach here. But I'm wondering, now that you've done this work of creating a table as a way to explain this, if we might encourage future writers to think about presenting their information in that format that might be a little more
it's user friendly,
condensed.
especially for people to apply it in their practice, certainly. And it gives a nice way of being able to look at the critical thinking process and the steps that are involved with that. Absolutely. Well, and in fact, when you mentioned Ms. Burns's case report, and while I was working with Sylvia on that, Karen Boulanger and I were developing the TMB adapted care guidelines, which is how to report case reports. And we were adapting the medical model of that for therapeutic massage and bodywork, or TMB related case reports. And it was from that we actually put in, for the intervention description, a table would be a good way to present this. But I must say that Rhonda Marie did an exceptional job of doing it in narrative form. And she has this really intuitive approach to it, where she talks about, this is the rationale, this is the information I had, this is the rationale, and this is why I did this, and then this is how it worked out. And it's just, it really, from a rhetoric standpoint, it really flows so nicely. I would like to share some of this with my doctoral students.
Oh, nice. Well, we should send her a send her a note to make sure that she listens to this research, Perch.
So the only qualm I have, though, is that she calls a 44-year-old woman elderly.
60? No, she was in her 60s.
Oh, no, yeah, 66. Still, 66-year-old woman elderly. But that's okay. So she is a woman in her 60s versus elderly. But
a woman just coming into the best part. So yeah. Nice. That's
so
really.
Let's talk about the treatment approach, though, that she had.
Okay.
So she does go through the techniques, certainly. So it was a treatment approach over 2.5 weeks. There were 5.
And she saw her twice a week, I think, right?
Yes, twice a week, and there were 5 total treatments. She broke the session down into 1-hour sessions, but it was 45 minutes of table time and 15 minutes of stretches and encouragement. And I really want to point this out and highlight this piece, is that she talks about the encouragement as a key and integral part of her intervention. And she talks about it from the standpoint of, from the subjective piece, is that people tend to do better, and she cites the literature. People tend to do better when they feel like they have support, when they feel like they have agency, when they feel like there is something on the other side. And this is a place that
they need to be reminded of that. You know, when we get stuck in pain that lasts for a long time, it's really easy to forget that there was a time that you weren't in pain.
Right, and that you can get there again. And so she integrated that piece and talked about it in her treatment approach, and she documented it. And she also documented the fact that she assigned stretches. These are the stretches that she assigned, and the fact that the woman complied with them. And then it talks about the subjective pain that she was experiencing, and that went way down. And the big piece was, so the woman was already taking Celebrex for stuff that was going on in her knees. But in addition to that, because the neck pain wasn't being addressed with that, then she was also taking the NSAIDs.
Right.
And with the other pieces and the accumulation of taking that over time, she wanted to get off of that. And by the end of this, she had come off of that. So she's still on the Celebrex for other pieces, but she's able to eliminate the need.
The other anti-inflammatories, yeah.
And so here again, I love talking about this client-centered, patient-centered outcomes.
Patient-centered outcomes,
and
right.
This is something that's important for her. And while there might still be a little bit of pain sometimes, it's not to the profound effect that it was beforehand. Remind me, Ruth, did she do a follow-up on this? So after the sessions were over, or I'm thinking of a different one.
Yeah, no, I think you're thinking of a different one.
Yeah.
I don't think we have information on that here. So we don't know.
Yeah. But it certainly sets a really nice platform for, an MD or somebody else who has somebody with DDD They go to their PubMed, they do a quick look for massage. Ooh, and massage. Oh, look, here it is. Yeah, you know what? This could be helpful for you. This is open access. The patient can take it to a massage therapist, and they could potentially replicate this. Excellent work. Really important, establishing massage for DDD and future pieces.
I'm glad you reminded us of, oh, go ahead, Ruth. I'm sorry.
Well, and what Nikki just said is in that example that you just gave, gives us virtually everything that we need in case reports. We need them for ourselves to look at what other people have done, and we also need them so that referring physicians can look and say, oh, this is what a massage, this is what a skilled massage looks like. Yes, I can get behind this for my patient.
And when it's articulated so well and enmeshed in the literature and enmeshed in the language that they are interested in and find reliable, it's really important. It speaks very well for the field. It speaks very well for her treatment approach, and for case reports in general. So I think this is a really nice example of the impact a case report can have.
Yeah, that's similar to what I was going to mention as well, Ruth, is I'm glad that, Nikki, you brought up the bridge this is between the massage therapy community and the medical community. So, this kind of work is another piece of that bridge in my mind, this kind of stuff. So that's great.
Yep.
Thank you. So with that, anything else, or should we wrap up?
I think this one's a good done. Yeah.
Okay, wonderful.
Okay.
Well, thank you. Thank you both so much, as always. Real pleasure, and thanks so much, everyone, for listening. We appreciate that. Sorry for my scratchy voice, my allergies as well. Hopefully I'll be sounding a little bit more normal next time around, but thanks for being with us today, as always. You can find us online at massagetherapyfoundation.org, where this podcast is in video format on our blog, and also via podcast, via iTunes and Stitcher in audio format. You can subscribe very easily there as well. So don't forget to go to ijtmb.org and do a search for the articles we discuss. For this one, you can probably do a search for degenerative disc disease, and it'll probably pop right up there in the first top of the list there. And you can download the full text again, it's free. And we encourage you to do that, and we appreciate it.
And we'd love for listeners, please, to, if you haven't already, please to subscribe to the IJTMB.
Yes, thank you.
All it means is that you get an email 4 times a year telling you that the new edition is out and giving you an instant link to get to it. But when we have a healthy number of subscribers from a nice geographic distribution, it reflects well in the journal, and that makes good things happen for us. So please help us out by subscribing to the journal.
Yes, thank you. And 4 times a year, that's about as unobtrusive as you can get. I mean, 4 emails a year. If you can't handle 4 emails a year, then you're probably a little too overwhelmed. So that's a great benefit. So thank you both. Thank you, Nikki. Thank you, Ruth. And thank you so much for listening. We appreciate our community that supports us on Research Perch. So we will look forward to chatting with you next time around. Thanks.
Thank you for joining us for this episode of Research Perch. Please send feedback or questions to perch@massagetherapyfoundation.org. See you next time.